and more perfected. I wanted to start with a conversation around equity, more so and how it kind of relates to lung cancer or any type of health issue that we're talking about. But lung cancer is the important issue that we're talking about today. Health equity. Let's use plain language with anything we're talking about. Basically, it's the opportunity for all people to have good health. Health inequities are those unfair differences that prevent people that have that opportunity, and disparities, pretty much how it sounds, it's the reasonable or measurable gap or distance between something that you're measuring. So, what's your name?
Ron.
Ron?
Yeah.
So there's a disparity between me and Ron in terms of distance. I have now closed the gap. I'm in his personal space. But that's what, we hear a lot of. Raise your hand or blink twice really hard if you ever heard the term or the phrase, we want to eliminate health disparities. Everybody's raising or blinking, right? The thing you have to say to yourself about that is that taking the conversation far enough? Are we really addressing the things that we need to address, or are we just hitting surface level? Are we really looking at those drivers and determinants of health, or those things that can greatly influence our health and well-being? Another conversation we need to have is understanding that equity and equality are not the same thing. So a lot of us have seen this graphic before, right? So this is maybe not something new. Let me show you something different though. We call this the hidden fences of health equity. So there's the first two boxes. One, you have equality where everybody gets the same thing. You have equity where people are met based on their needs. Then you start going to a few other boxes, right? A few other places. So third box we call liberation, where it gets rid of the fence, gets rid of the other enhancements. But it doesn't go far enough. We got to make sure that we're including the people that we serve into the process. So we have to make sure that we're not just playing a game for someone, but we're involving the people that matter into the process. So it's one thing to have a seat at the table. It's a whole other thing to have a voice while having that seat at the table. And that's what's important. Some of the common barriers that we all face, see, deal with on an everyday basis, you'll see up here. Now, some of the other ones that you'll see when you dig a little deeper may be connected to care. So in this case, we'll talk about care. So there's certain labels that may come out if you're getting care, and a few of those you see up here. One is non-compliance. Anybody ever heard that term? It's like a dirty word, dirty phrase, right? You're so non-compliant. But does that dig deep enough into the why or how? No, it doesn't. It just says, based on this stat or based on this engagement, you're not doing what we told you to do. Doesn't take into account other type of factors, family, home, weather, things like that, life in general. Another term is frequent flyers. You may hear this more in a hospital setting. People who are engaging in the system of health and healthcare frequently. And then one that always gets me is colorblind care. This is kind of a notion of people saying, I don't see color in my patients. Problem is, I need you to see color in your patients because it may affect the way that you treat said patient. I need you to see where they're from. I need you to see the issues that we all deal with. Your zip code, geographic location, it can change how you live, work, play, engage, die. I think it's going from Wake County to the eastern coast of North Carolina. You start losing, I think from one county to the next, you're losing like 7 years of life expectancy. So you go from like 80 in Wake County to like 73 in the next county. Food access. Y'all missed a great lunch and learn that we had today at the state with our office as part of our Health Equity Lunch and Learn series that we talked about food security and how important that is to not just be fed or get people access to food, but how that plays a part and a lot of the other things that you sometimes don't think about. If you think about students who are in school from preschool on up, if you don't have access to healthy meals, it can affect your performance. And that can look into, start talking about the adverse childhood events and experiences, or ACEs. All that plays a part into that. And then, like we said earlier, the lack of plain language. If I can't explain something to somebody, like I was talking to a child, or like an older adult, like a grandparent, uncle, or aunt, then what are we really talking about? A lot of definitions in health are these super long paragraph definitions that nobody can understand. It's like, okay, you read all that book to me, but what does it mean? How do I make it real to me? So, I like to call these SEEK drivers and determinants of health, and that's looking at the social, economic, environmental, ecological, and cultural factors that can greatly influence your health and well-being, the way we live, work, play, engage. What's interesting about this is a lot of people tend not to think about culture as a factor, but it's a huge factor. I used to work at Duke Cancer Institute as a patient navigator, and a lot of that came up a lot in terms of just being respectful of one's culture, one's experiences, and the way that they live. And so we can't discount any of this as we're going through our connections with people, and it's just a bigger version of what we're talking about. It's one thing to tell you about what the problems are. One thing we're trying to do at the state level is make sure that each one of these problems have solutions. And so you'll see rolled out probably fall of next year from DHHS is some pilots around healthy opportunities. And so getting to the root cause of some of these issues and mapping out the resources that go along with them. Anybody know about North Carolina? Nobody ever heard of it? Okay. Not the school, we're just talking about North Carolina as well. Because I'm sure we probably have some good fans in there. Oh, good. I mean, other than the people that work at Duke, they get a check, of course. All right, so can I be blunt with you all? North Carolina, we're very white. It's not a bad thing, it's not a good thing, it's just what it is, it's the thing, right? So we're looking at a population 18 to 64, we are 65% white. You look at the population under 18 here in North Carolina, it is 56% white. What changed?
People have babies.
Okay, people have babies. Who had babies?
African Americans.
And?
Or
Hispanic, Latino, Latinx populations almost doubled. So what we're seeing in a national trend and in North Carolina is by the years 2030, 2040, 2050, the total minority population will make up the majority population in this state and in this country. Why is that important? It's important because based on how people identify, whether it be by race and ethnicity or sexual orientation or whatever, it can predetermine, using advanced predictive analytics, the burden of health and healthcare systems if they don't change. We already see that burden now. So if it doesn't change, then it's going to get worse. So it's important to understand that. It's also important to understand that an oversaturation of one population can change the total outlook of some of our indicators. So in this year, 63% of all jobs require post-secondary education. That's important. Because if you don't have education, you can't get a job. Can't get a job, you're probably going to live in poverty. Living in poverty, you probably can't get the health care that you need, right? Oh, poverty. Who knew that was coming up next? I did. So it's thought that 1 in 5 North Carolinians live in poverty. Broken down by race and ethnicity, all the all the minority population that show up here are even 1 in 3 or 1 in 3.5 to be in poverty. Which population that's on there is not in that 1 in 3 or 1 in 3.5? Right. So when you add the oversaturation of one population and mix it up with the rest of the populations, so it changes how the total outlook looks. There's a lot of looks. Let's take unemployment. Year 2015, unemployment rate for the state was 5.5% total. You break it down by race and ethnicity, it is 3.9% for white people, 6.9% for Latinx people, and 9.6% for African Americans. See how one population can change the overall outlook of something? It's pretty significant. So when we think about how these things happen or how they're influenced, we think about all these factors here, but one I want to raise up is policy. Anybody ever heard of policy? Y'all understand policy? Somebody want to tell me what policy is? I know you just ate, so you're not asleep yet.
Laws and regulations and that determine.
So let's use plain language for that. Rules, right? Law. He's right though. So laws and rules, right? Don't raise your hand, but blink twice really hard if you've ever heard this policy. What happens in this house stays in this house. In or out, don't be wasting my good heat or air. Don't touch my radio. Those are policies. I mean, I'm sure y'all can think of like 100 more right now of things that you govern yourself by. You know, even at work, there are certain things that may be unwritten rules. You don't eat somebody else's lunch if your name is not on it. But somehow, some people's lunches get missing. Okay, I see some guilty people in here. So when you think about policy, don't just think about the rules and regulations that come out from a General Assembly or Congress, but also think about what are those things that you do every day in your house, in your car, around other people. Who allows somebody to smoke in their car? I mean, I guess even if you did, you weren't going to raise your hand in here. But that's policy. Whether we think about it in that lens or not. We can go into a whole bunch of other conversations around here, and I just want to make sure I'm mindful of the time, because I put way too many slides up here, and I wanted to get to at least half of them. So, another thing that we have to think about when we're talking about equity is the context of the conversation around racism. Now, usually this is where people start cringing, like, oh my God, he's going to talk about racism. Racism has more to do with unshared power than it does skin color. Skin color is very important to the equation, is because this thing that we call race is not so much as real as we make it, but we have made it real. So racism does exist because some people have power and influence over others, and it's not shared. When you get the slides, click on the hyperlink that says Gardner's Tale and watch Dr. Kamar Jones go through a whole allegory on race and racism. I'm not even going to try and do it because I would just do it as a service, but she's amazing. And or you can just go look it up. She does a TED Talk on it on YouTube, and that's what the hyperlink will take you to. It's amazing. She's an amazing woman. She was just down here last year at UNC, and she's just a wealth of knowledge. She used to be at CDC, and then now she's at Morehouse School of Medicine. Just a genius level talent and intellect. So do yourself a favor and look at that when you get a chance. Of course, we weren't going to just leave here without talking about lung cancer. But I will say this, I'll go through these slides a little quickly because I know there's more people who are going to come after me that have more insights on this. I will say that lung cancer is very surprising statistically in this country. And some of the things that happen on a country level are different than what happened on the state level. So we're looking at the new cases in the United States, well, the rate of new cancer, or new cases in the United States, and you kind of see where it's kind of centralized, and then looking at the cancer deaths, it's kind of like similar, right? You like the colors? It really helps tell the story. And this is for lung cancer, right? When we look at it from this also perspective, statewide versus the whole country shows that black men are more susceptible to have lung cancer, right? They make up some of the more new cases. But when you get to the statewide data, it's a different conversation. So it's not saying that African Americans or black men don't get it. It's just that in North Carolina, they don't get it as much as whites. But here's the problem with what we were saying earlier. The conversation is around making people well. If I told you we could end disparities right now, would you believe it? Anybody want to raise their hand and say yes?
What was the question again? Sorry.
Can we end disparities right now, before we leave this room, before we leave the solution center? Using the conversation and language that we want to eliminate health disparities. Period. Anybody wants to take me up on this offer? Can I get one? Will there be one? Alicia Barfield, raise your hand. Raise your hand. Okay, so I got Alicia with me. She's the only person in the room. So y'all see this. She was voluntold. So if we said we were going to eliminate health disparities right now, that's mean closing the gap or the measurable distance, as we did earlier, right? We could do that, right? Today. Only Alicia is forced to say yes. Okay. Here's how we do it. We make people sicker. If everybody's sick, then we're on the same level playing field. We have closed the gap. That's not what we want to do, but we have essentially ended the period at eliminating health disparities. It's not ethical. It is not the goal we're trying to get to. So we have to use better language by saying that we want to eliminate health disparities by using health equity strategies so that all people can experience good health and opportunities to have good health. So therefore, we want people to be more well than being more sick. So if we're not careful, we could end up making people more sick to get to a goal and not really achieve the intent of what we're trying to do. Oh, that was cute. So we see here how lung cancer can affect people differently. If we're looking at how they identify as male or female, or men and women, or and the different risk factors. So it's always interesting. It seems like more men are smoking than women. It's a different time. But it also seems like more women are being exposed to radon. That's pretty interesting. I'm not a researcher. We can talk about that later. But I do want you to know that in North Carolina, we're looking at the incidence rates, and the trend data is showing us there's some interesting correlations to the location of what's going on here. What doesn't look as bad? There's a certain area, right? Yeah. What is it about the triangle?
The best hospitals.
North Carolina is about 86% rural. It's easy to say that because it's 100 counties, so you just find out how many rural counties you have in the state and put a percentage behind it, right? If you're not showing equitable practices across the board, then you're going to see little pockets, little areas that may be more urbanized that will have better access to better resources. What we're trying to do is make sure we start having conversations of spreading those resources, mapping them out, and make sure people know where they are. And when we're looking at the mortality rates, the maps look very similar. So we got to do something to make sure that we're changing it. It starts today, it starts here, making sure that we're recognizing what we can do collectively as a group and even as individuals. So we got to think innovatively. And it's just what we got to do, right? So everybody took their pictures, right? I want you to do something with those pictures at your convenience. I want you to share it on social media. I want you to share it with friends. I want you to tell them why you are sharing that, because you're here in this room and you're trying to spread the message. I want you to put Lung Cancer Initiative as a hashtag, or LCI as a hashtag. Heck, you can even use my own personalized hashtag, which is CPWMPA. Shameless plug. But make sure people understand why you're here and why you're sharing that picture. So social media and telehealth and telemedicine have gone a long way of us just telling our stories, being more interactive, and just being more engaged. And so reaching populations and having conversations that normally you wouldn't have back in, I won't say when I was born, but back when I was born, we didn't have that option. You know, I grew up privileged because we had a Commodore 64 in the house and the floppy disk. Not every household had that. Now, people have like iPhone 11s and 13s and Samsungs, and it's totally different. But use this moment. If you ever heard of photo voice, anybody ever heard of photo voice? Instagram is nothing but photo voice. It's a tool that you can use to spread your message. Picture, caption. Picture, caption. That's all it is. It helps with this. Patient navigation, extremely important. The goal of patient navigation in its truest sense is to link communities to the health system and health system back to communities. If you're not seeing that happen, then there is something wrong in the connection or the bridge that's supposed to happen and do that. It also is supposed to eliminate barriers. So those barriers we talked about earlier and the ones we didn't talk about, patient navigation is set up to address those barriers. We think about faith and those intersections of how we all connect, or some of us connect. Faith is a great way to make these conversations happen. And if we're not utilizing where people engage, then we have to make sure that even if it's not through faith, maybe it's where they get their hair done. Maybe it's in the grocery store where they meet. And so making sure that we're making those connections, not just at the hospital where it's so threatening and there's so much information being thrown at you at one time, but places that you probably wouldn't expect sometimes. So, another shameless plug, our office released the Health Equity Report for North Carolina in April during National Minority Health Month. And this is a great tool for you to just get some information about the state and some of the issues that we're seeing. And then also, Department of Health and Human Services in North Carolina released an interactive map, the Social Determinants Interactive Map, that you can go and click on all 100 counties and get just amazing data. And what the goal total is to look at the need and be able to stack the need up to the resources and combine it and see where there's gaps or disparity. One last innovative strategy and approach is to think about a young lady whose name was Anita Woodley. Back in 2014, October 2014, when I was at Duke, she did a one-woman stage performance. She took information from focus groups with FHI 360 that they had with the community around prostate cancer and took all the data and they broke it down into 4 themes. She turned those 4 themes into 4 characters and she acted them out for free at the Carolina Theater in Durham. And then we had people from Duke and the health department there to ask and to answer questions that were asked by community members. So it's taking your data and giving it back to the community. We don't see that enough with a lot of people or some institutions who are collecting data from communities and never disseminate it back in a way that's powerful. So this is an amazing strategy and approach to do so. So I'll leave you with this and then bring on the next speaker because I will have to leave and I will make sure I leave some cards because I have a 7-year-old who has not seen me because I've been in San Diego all week at APHA. But in times of crisis, the wise build bridges and the foolish build barriers. King T'Challa from Wakanda.
Nice.
Questions?